Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important series. In today's topic of discussion, we are going to start off with a very interesting series, that is the gross specimen series, which is a part of your MD DNB pathology practical examination. So today we are going to start off with the part 1, wherein we are going to discuss the specimens from the cardiovascular system and respiratory system with total of 12 specimens. Okay. So remember one thing, that before we start off, keep one thing in mind, that surgical specimens are asked in different ways in your exam, and they can be asked interchangeably. So the first way of questioning with regards to the gross surgical specimens is that the gross specimens wherein the questions regarding the core grossing, that is, what are the steps of grossing, what are the different sections that you will give, what margins you are going to take, what are the fixation methods, etc. So all these questions are usually asked to you in the grossing station. Okay, in the grossing station you are basically asked about the core grossing, okay, wherein your different stagings might also be asked. Okay. Now the second important thing that is there, that is the Mueseum specimen. Sometimes you will have a table viva. Everyone is having a table viva for Mueseum specimen. These are also surgical specimens. Okay, these are usually jar mounted formalin fixed specimens. Okay, wherein basically more importantly we have to give a gross diagnosis over there. Okay, then we have to give the gross differentials, and there are certain typical viva questions which are asked over there. Okay, and in today's topic of discussion we are mainly going to concentrate on this part, the Mueseum specimens. Okay, but remember one thing, in any of these stations, okay, the questions from either the steps of grossing or autopsy related questions may be asked to you also, okay, in the Mueseum specimen. Okay, and the third part is the autopsy, wherein autopsy related questions are quite different. Okay, what are the methods of autopsy, what are the different types, okay, how different organs are, like how do you retrieve the brain, okay, what are the methods of dissection of the heart. Okay, so they might ask you all these questions. Okay, so that is a different completely different lecture. So this will be covered separately in our application. Okay, so in today's topic of discussion we are mainly going to consider this part, okay, the Mueseum specimen. Okay, because this grossing part already it has been covered under the grossing course. Okay, in the grossing course it has already been covered, so we are not going to repeat those questions over here, but rather we are going to cover those important questions which are usually asked in your practical exams during your table viva, wherein the jar mounted formalin fixed Mueseum specimens are kept. Now remember, these Mueseum specimens can also be a part of your problem cards. Okay, in your problem card series they might also include the Mueseum specimens. And remember, during your Mueseum specimen viva usually the autopsy related questions are asked, and autopsy related questions can also be asked in your grossing station as well. Okay, or it might be asked completely separately as a separate viva. So what I want to say, that gross specimen, the grossing part, the Mueseum specimen and the autopsy, these questions can be intermixed and can be asked at any point interchangeably. Okay, this part has already been discussed, so we are not repeating again. Autopsy part has not been covered yet. It will be covered one single lecture. A short 1 hour session will be taken on autopsy, wherein we will discuss in details about the important relevant questions which are asked from autopsy. But currently in this particular session, in this series, that is the gross specimen series, we are mainly going to concentrate on the Mueseum specimens. Okay, wherein you are having a jar mounted formalin fixed specimen, and you have to describe the specimen, give your gross diagnosis, what findings you are seeing, what are your gross differentials, and important theoretical exam viva related theoretical questions related to your gross description. Okay, so let us begin. Now before I start, whatever I have already told you, the same thing is written over here, so I am not going to repeat the same over here. But what is very important, that whenever you are getting a Mueseum specimen, so it is jar mounted, so you always have to say like this, whenever you see the specimen, it is a jar mounted formalin fixed specimen, okay, showing lungs, heart or whatever. If it is not a complete organ, if it is a cut section, then you say it's a cut section of heart or longitudinal section of of the lungs, something like that, or it is a cut open specimen of an aorta, abdominal aorta, like that. Or even if for example operative names of specimen, like if the breast is there, MRM specimen is there, so MRM specimen is there. Okay, then you have to point out if any abnormality is there, what is the site of the abnormality, describe that abnormality, how it looks, and you have to give an impression of your, from the gross examination, you have to give a diagnosis. Okay. So this is what is very important in these Mueseum specimens that we are going to discuss. Okay. Okay. All other things we have already discussed, so I'm not going to discuss again. So this is the only thing I wanted to say. Okay. So without wasting any time, let us begin the first part, that is the cardiovascular system. Let us look at the first specimen. So as you can appreciate over here, you can see this is the cut open section of the heart, okay, wherein you can see multiple small 1 to 2 mm warty masses in the form of verrucae, okay, which is present where? Along the lines of closure. This is the line of closure, right, of the mitral valve cusp, okay. Over here, if you see the chordae tendineae, they look more or less normal only. The chordae tendineae, they are more or less normal. So we can see vegetation. So it is basically an acute rheumatic heart disease. Okay. Second, if you see, second thing, so over here I have given a clinical case scenario also, that a 40-year-old woman with a chronic valvular heart disease was admitted for congestive heart failure. So herein you can see that this is the cut open section of the left ventricle. So what are the findings that you will see? Very importantly, if you see the mitral valve, you can see there is a thickening of the mitral valve. Okay, the mitral valve is thickened, severely thickened. Look at the chordae tendineae. The chordae tendineae, it is also thickened, and okay, and very importantly, you look at the condition of the left ventricle. It is hypertrophied. Okay, stating that there was a mitral valve abnormality. Mostly the mitral stenosis was there, because of which there was left ventricular hypertrophy. Okay, so what is the diagnosis? It's the case of a chronic rheumatic heart disease. Usually vegetations are not present in the chronic disease. In the chronic disease, you will see severe thickening of the valve. You will see the thickened chordae tendineae that I have already showed you, and hypertrophied left ventricular myocardium, as we can appreciate over here. Okay, so this is the case of a chronic rheumatic heart disease. So I have shown you both the cases, both the acute and the chronic rheumatic heart disease. Now, this is a case wherein I have just highlighted you what is it. It's a gross case. It's a mitral stenosis. A fish mouth appearance is there because of the mitral stenosis, as we can appreciate over here. So what is the causative agent in rheumatic fever? It is the group A beta hemolytic streptococci in the throat. Name and describe the characteristic microscopic lesion of rheumatic fever. So you might just be asked to name what are those. So it is called as the Aschoff nodule. Some examiner may ask you describe it. So it is nothing but circumscribed inflammatory nodule composed of areas of fibrinoid necrosis surrounded by mixed mononuclear inflammatory cells, that is lymphocyte plasma cells, and plump activated macrophages. Now this plump activated macrophages, okay, they are called as Anitz-Chekhov cells. They are having abundant eosinophilic cytoplasm with wavy ribbon-like nuclear chromatin, also called as the caterpillar cells. Okay, so this is the characteristic microscopic lesion of rheumatic fever. What is Aschoff nodules and what are Anitz-Chekhov cells? You know. Now, which layer of the heart is involved? Okay, so there is a diffuse inflammation, and Aschoff bodies may involve any of the three layers of the heart, resulting in pericarditis, myocarditis, or even endocarditis. So there is a pancarditis in rheumatic fever or rheumatic heart disease. Now, which valve is most commonly involved? Now, remember, it is the mitral valve, which is virtually always involved in chronic rheumatic heart disease. It is affected in isolation in roughly 2/3 of the cases, and along with the aortic valve in another 25% of the cases. Tricuspid valve involvement is infrequent, and pulmonary valve is rarely involved. Now describe the vegetations which are seen in rheumatic heart disease. So rheumatic heart disease, it is a prototype of verrucous endocarditis involving the left side of the heart, mainly characterized by small 1 to 2 millimeter warty masses or verrucae present along the line of closure of the valve cuffs, and it is not seen in chronic fibrotic case. Okay, remember I have already shown you over here warty verrucous, as you can appreciate over here, warty verrucous vegetations along the line of closure of the valve cuffs. Over here is the mitral valve. Okay, now next is, now when the question of vegetation comes, then the gross differential will be there. So what are the other conditions showing vegetations in the heart valve? So these are infective endocarditis. So over here you will see large, friable, bulky, irregular mass on the valve cuff that may extend onto the chordae, may involve any part of the valve. Then second is non-bacterial thrombotic endocarditis, NBT, typically exhibits small 1 to 5 mm sterile bland vegetation, usually attached at the line of closure. Now remember, this kind of endocarditis is also called as marantic. The word marantic is coming from malnourished. Okay, because, and they are mainly seen in debilitated cancer or sepsis patients. Thirdly, we are having Liebman-Sachs endocarditis. They have small or medium sized vegetations on either or both sides of the valve leaflets, mainly in patients of systemic lupus erythematosus, SLE patients. Okay. The next important question is enumerate the methods of cardiac dissection. So what are those methods? So we are having the inflow outflow method, short access method, window method, valve plane method, 4-chamber cut method. All these will be discussed in details in the autopsy series. Okay. Now the next question is, what are the morphological changes which are seen in case of chronic rheumatic heart disease involving the mitral valve, and what is its fate? So what are the morphological change in the chronic RHD? What are the things that I had shown you? Can you see that there is mitral valve, there is a severe thickening of the mitral valve, thickening of the chordae tendineae, okay, as well as hypertrophy of the left ventricular myocardium because of mitral stenosis, okay. So there is a leaflet thickening, commercial fusion and shortening and thickening and fusion of the tendinous cords, resulting in what is the fate? It can lead to mitral stenosis and mitral regurgitation. And remember, Aschoff bodies, they are rare in patients of chronic rheumatic heart disease. Now, what is fish mouth stenosis? In rheumatic mitral stenosis, calcification and fibrous bridging across the valvular commissures creates a fish mouth or button hole valve that we have already seen over here. Okay, it's crystal clear to everyone. Next, what is McCallum's patch? Okay, so these are macroscopic subendocardial lesions seen in the left atrium secondary to regurgitation jets of mitral regurgitation. Okay, I hope this is crystal clear to everyone. And what is the diagnostic criteria for rheumatic fever? It is the revised Jones criteria. The diagnosis requires the following. Number 1, evidence of a preceding group A streptococcal infection and presence of 2 major manifestations or 1 major and 2 minor manifestations. So what are the major manifestations? It is migratory polyarthritis, pancreatitis, subcutaneous nodules, erythema marginatum, Sydenham scoria. Minor manifestations include non-specific sign symptoms like fever, arthralgia, or elevated blood levels of acute phase reactants. Okay. So with this, we have completed the first 2 gross specimens, that is the acute and chronic rheumatic heart disease, and the different findings we have already seen. The next important case is the case of myocardial infarction. So what you can see, the 72-year-old man with a crushing severe chest pain, vomiting and severe shortness of breath. So ultimately the patient has died, and then the autopsy was done, and then the sections were taken, and then one of the sections was preserved. So over here what you can see is a cross section of the heart showing a pale area. Can you see certain pale areas over here? A pale area of myocardial infarction in the posterior wall of the left ventricle. The right ventricle is seen, okay, as you can see over there on the right hand side, the right ventricle can be seen. So it is a case of a myocardial infarction. So why is the infarcted area pale white compared to the surrounding myocardium? Due to the fibrosis. So what is very important, that in your gross differentials, when you get a myocardial infarction case, they will ask you that what are the changes that appear grossly or macroscopically over a period of time. So the first important question that you have to know, that when does infarcted areas become apparent macroscopically, and what are the changes appreciable grossly with time? So what you will see, that firstly, after 12 hours of infarction, you will see reddish bluish area of dark mottling. So the macroscopic changes appear only after 12 hours of infarction, not before 12 hours. And how you will see certain areas, focal areas of reddish bluish area of dark mottling will be seen. So what are the changes, macroscopic changes? In 12 to 24 hours, you will see dark mottling, that is reddish bluish area, which occurs because of congestion and extravasated blood. In 3 to 5 days, you will see that the lesion is rimmed by hyperemic zone of highly vascularized early wound healing, that is granulation tissue. In 7 to 10 days, maximally yellow tan and soft in center with depressed red tan margins. In 10 to 14 days, you will see red grayish depressed infarct borders, and in few weeks, the infarcted area will evolve into a fibrous scar. Okay. Now, do you know of any histochemical stain for identifying infarcted area? Now remember one thing, why it is very important, and this question, if MI is there, myocardial infarction is asked, this question will be asked 110% to everyone. So why it is there? Because as we have seen that the gross features of MI is appreciable only after 12 hours, not before 12 hours. So MIs less than 12 hours old are usually not apparent on gross examination alone. So we have to go for a histochemical stain. So if the infarct preceded death by at least 2 to 3 hours, it is possible to highlight the area of necrosis by immersion of tissue slices in a solution of triphenyl tetrazolium chloride. So what happens over here, this histochemical stain imparts a brick red color to intact non-infarcted myocardium with preserved lactate dehydrogenase activity. Because dehydrogenase leak out through the damaged membranes of the dead cells, and infarct appears as an unstained pale zone. So less than 12 hours if you use this dye, triphenyl tetrazolium chloride, so the intact non-infarcted myocardium will take up the brick red color, whereas the infarcted areas will be unstained. Okay, they will appear as pale areas. Okay, and what is the reason? You know, because of the LDH activity being intact in the non-infarcted myocardium and LDH being lost in the infarcted areas of the myocardium. Okay, next, what are the complications of myocardial infarct? It includes arrhythmias, myocardial rupture, pericarditis, mural thrombi, progressive heart failure, ventricular aneurysm, right ventricular infarct, papillary muscle dysfunction leading to mitral regurgitation and contractile dysfunction. Name some serum markers of MI, enumerate the newer biomarkers of cardiac injury. So remember, we are not discussing this because it has already been discussed in the clinical pathology session, wherein we have discussed in details about them. So we are not discussing them again over here. Okay, so you might discuss it later on as well. Means you might read it in your clinical pathology course. Okay, so we are not discussing them, but this will be asked. Very important question. Now next question is, why in a transmural infarct a narrow area just beneath the subendocardial region escapes infarction? So the answer is, a very narrow zone of myocardium immediately beneath the endocardium is spared from necrosis because oxygen and nutrition are provided by diffusion from the ventricle. Okay, this is a very important question and everyone will be asked about this. Next specimen is, as you can appreciate, a 75-year-old man with a history of long-standing poorly controlled hypertension. So what you see over here, you can see gross pathology of concentric left ventricular hypertrophy. The left ventricle is at the right in the image, and they are serially sectioned from apex to the base. So you can see serial cross sections of the left ventricle. You can see the hypertrophy. Okay, you can see the hypertrophy of the left ventricle. So there's the left ventricular hypertrophy, as we can appreciate over here. Okay, so the next question will be, define hypertrophy, enumerate the examples of hypertrophy, and what are the mechanisms of hypertrophy. Okay, this is a very commonly asked question in your exam also. So hypertrophy is defined as an increase in the size of the cells that result in an increase in size of the affected organ. It occurs in tissues that cannot divide. Now hypertrophy is of two types. One is physiological hypertrophy, for example secondary to increased demand in the muscles, or secondary to increased hormonal secretion, example secondary to the estrogen which is released during pregnancy, okay, which leads to uterine hypertrophy of the uterus. So what is the basic mechanism over here of physiologic hypertrophy? Due to an increased production of cellular proteins. Another type of hypertrophy is pathologic hypertrophy, which we have seen over here. That is a case of a left ventricular hypertrophy, which occurs usually because of increased demand, and for example over here is heart, secondary to hypertension or secondary to a valvular heart disease can show. So we have just seen a rheumatic heart disease. We have seen that in a case of a chronic rheumatic heart disease, there was mitral stenosis leading to left ventricular hypertrophy also. Okay, so the mechanism of physiological hypertrophy we have seen because of increased production of cellular proteins. Now we are going to see the mechanism of pathological hypertrophy. So molecular mechanism of hypertrophy, that is the hypertrophy of the heart. So because of increased workload, that is mechanical stretch, or because of release of agonists like alpha adrenergic hormones or angiotensin or endothelin release, or because of release of growth factors like FGF, IGF-1, TGF-beta, all of them lead to stimulation of signal transduction pathways. The PI3K-AKT pathway, which is mainly responsible for physiologic hypertrophy, whereas the G protein coupled receptor or GPCR pathway is responsible for pathologic hypertrophy. They are going to stimulate transcription factors like GATA4, NAFAT, MEF2, which is going to induce fetal or embryonic genes. Now this fetal and embryonic genes, what they do, they increase the mechanical performance or they decrease the workload. How? For example, adult protein alpha isoform, that will be converted to a fetal protein beta isoform, which is more economical. Okay, secondly, ANF gene, there's an increased expression of the ANF gene, which leads to increased sodium and water excretion, thus reducing the hemodynamic load on the heart. Second mechanism is increased synthesis of contractile protein, okay, increases the mechanical performance. And lastly, increased production of growth factors, okay. So this is how the molecular mechanism of hypertrophy, that is especially the hypertrophy of the heart, works. Okay. So all the questions have been addressed over here. Examples of hypertrophy, definition and mechanism of hypertrophy. Next, if you see, an 82-year-old male with hypertension and dyslipidemia. Okay. So over here, what you can see over here, it is a cut open section of the abdominal aorta along its length with extensive formation of raised yellowish atheromatous plaques, as you can appreciate, raised yellowish atheromatous plaques, okay, with ulceration. There are areas of ulceration as well. Now, characteristic lesions are also present at the branching point. You can see the yellowish raised areas at the branching points as well. Okay, it's the case of atherosclerosis, as we can appreciate. Again, a very commonly kept exam museum specimen. So the first question the examiner will ask you, and he will confuse you. What is arteriosclerosis? What are its variants? So arteriosclerosis literally means hardening of the arteries. It is a generic term for arterial wall thickening and loss of elasticity. Okay, what are the different variants of arteriosclerosis? So number one is arteriolosclerosis. So arteriolosclerosis is specific for hypertension, and two morphological variants is hyaline and hyperplastic arteriolosclerosis. Then we have Monckeberg's medial sclerosis, fibromuscular intimal hyperplasia, and lastly atherosclerosis involving the blood vessels. What are the risk factors of atherosclerosis? So there are non-modifiable or constitutional factors like genetic variation, family history, increasing age, male sex, and modifiable factors like hyperlipidemia, hypertension, cigarette smoking, diabetes, inflammation, etc. So what are the common sites of development of atherosclerosis? In descending order, the most extensively involved vessels are the lower abdominal aorta and the iliac arteries, the coronary arteries, popliteal arteries, and the internal carotid arteries, and lastly the vessels of the circle of Willis. I hope this is crystal clear to everyone. Next, what are fatty streaks? So fatty streaks are composed primarily of lipid-filled foamy macrophages appearing as small flat yellow macules, which eventually will join with each other to form elongated streaks like this. Okay, 1 centimeter long or longer. The lesions are slightly, so they will become, in the end they will join like this. Okay, the lesions are slightly raised and do not cause any significant flow disturbance, and although fatty streaks can evolve into plaques, not all are destined to become advanced lesions. Now, what is the basic lesion in atherosclerosis? It is the atherosclerotic plaques. So what are they? They are yellowish tan raised lesions. Any superimposed thrombus over ulcerated plaques is reddish brown in color, as we can appreciate over here, reddish brown color over here, okay, of superimposed, ulcerated areas, ulcerated plaque areas. Now, this plaque consists of a fibrous fibrous cap and a central necrotic core containing cholesterol and other lipids. Now, plaques vary in size but can coalesce to form larger masses. They are patchy and rarely circumferential, usually involving only a portion of any given arterial wall. On cut section, the lesion therefore appears eccentric. Local flow disturbances such as non-laminar flow, that is turbulence at branch points, makes them more susceptible to plaque formation. Now, when do you call a plaque as complicated? If there is any rupture, ulceration or erosion leading to thrombosis, it is called a complicated plaque. Or if there is any hemorrhage into the plaque, atheroembolism, if it gives rise to atheroembolism or any aneurysm formation, okay, then we call it as a complicated plaque. Now, what are the steps in pathogenesis of atherosclerosis? So there are 5 important steps. I'm not going to stay over here because it has been discussed in theory, and by the time that you're reading them, so I guess that you will remember these steps, so they can be asked in your exams as well. So with this, we have completed this atherosclerosis as well, and we have completed the cardiovascular system in details. Next, we are going to start off with the respiratory system specimens. So coming to the respiratory system, so the first thing that we are going to see, a 27-year-old woman presenting with fever, night sweats and loss of weight along with chronic cough. So what do you see over here? You can see a specimen of the lung, or one side of the lung. You can appreciate a 1 to 1.5 centimeter area of gray white.